Thank you. We'll move on to Robert Moore, Chief Medical Officer, Partnership Health Plan of California.
Great. Thank you, Senator Hernandez. It's with great humility that I follow the distinguished speakers that have discussed many aspects of defining, thinking about, measuring, and addressing disparities in healthcare and health status. I'm the Chief Medical Officer at Partnership Health Plan, a family physician, and I'm going to talk a little bit about the role of managed care plans in addressing disparities in healthcare and health status. I've devoted my career to serving the vulnerable populations in California, first as a family physician at Community Health Clinical A federally qualified health center, serving low-income, predominantly Latino and largely Spanish-speaking population in Napa. More recently at Partnership Health Plan, a county-organized health system and a Medi-Cal managed care plan serving 523,000 members in 14 Northern California counties. In that time, I've learned a lot about health disparities, both through formal training, but also through some on-the-ground experience, analyzing data and caring for a diverse population. Let me give an example from 2007. Like Dr. Lown, I think an example really helps. At that time, the rate of newborns breastfeeding at 2 months of age was about 60%, both for Hispanic mothers and non-Hispanic mothers in the city of Napa. But in St. Helena, the rate was below 30% for Hispanic, mostly Spanish-speaking mothers, compared to 60% for non-Hispanic mothers. The demographics of these communities were the same. The cause of the disparity, the nurses in the hospital at St. Helena genuinely believed that Hispanic mothers didn't like to breastfeed, and so they started bottle feeding the Hispanic babies in the hospital. This is not unique to this hospital. The solution was to provide the data to the nursing leadership, educate the nursing staff, and monitor the change. The data was there actually before then, but the key to taking that data that existed was an intervention that occurred by a community-wide perinatal collaborative work group. So data alone does not drive change. It really takes some kind of work group to make that data take action. Medi-Cal health plans are mandated by DHCS contracts to conduct certain data analyses and perform certain activities related to disparities, which Sarah outlined, and I've also listed in my written remarks, which I won't go through, but were distributed to you all. In addition, further data analysis and collection, as has been discussed, will be helpful, and I have some suggestions which I won't go through either. But I wanted to talk about the elimination of disparities that really won't happen first by writing some additional contract requirements for the health plan, and secondly, just getting data by itself is not going to eliminate disparities either. Any organization seeking to make a significant impact on disparity of outcomes needs to have strong leadership and a systematic focus on improvement of outcomes. Again, legislating new contract requirements will not do this. For the last 15 years or so, the non-for-profit health plans of California are leading efforts to improve outcomes. They've increasingly expanded their horizons from providing cost-effective healthcare delivery system to a more community-wide sphere of influence, including supporting community-wide prevention and wellness efforts like Kaiser's Thrive campaign, funding community-based organizations to provide care navigation, case management services that address underlying causes of poor health, known as the social determinants, and most importantly, collaborating with community coalitions and public health agencies to make larger scale community-wide changes. One example is Partnership Health Plan has a multi-county, multi-stakeholder initiative to reduce opioid overuse, overdose deaths, and neonatal drug withdrawal. The other way that major impacts on health status can come is from a focused public health, public policy intervention, such as tobacco tax, seatbelt laws, child safety seats are examples. And lastly, the other way major changes can be made is through quality improvement advocacy organizations, such as the Institute for Healthcare Improvement's 1 Million Lives campaign, or the reduction in maternal mortality achieved very rapidly within a couple of years by the California Maternal Quality Care Collaborative. It is these major improvements in overall health status that have a major enduring impact on disparities. So what can the state of California do to support health plans and our provider partners in reducing disparities? I have 3 specific recommendations for the committee to consider. The first, ensure that the financing and structure of the Medi-Cal program itself is sufficient to prevent disparities due to having Medi-Cal, as opposed to commercial insurance. The state and the Medi-Cal managed care plans are responsible for the quality of care, but not in the areas of dental, alcohol, and other drug use disorders and the serious and persistent mental illness. If this care is inadequate, a disparity exists due to the inadequacy of the coverage itself. And secondly, in this point, through its oversight responsibility, DHCS monitors and evaluates the quality of care provided through Medi-Cal managed care plans. And this oversight must ensure equitable care for the entire Medi-Cal population, including beneficiaries who select a for-profit insurance plan to cover them. Second recommendation is to create a recognition program to showcase health plans, providers, or community coalitions that do have a major improvements in health disparities or the health status of a large vulnerable population. And I do take issue, I would differ with some of the folks who've mentioned a pay for performance for this. I think given the uneven state of health disparities data accuracy and collection, a pay for performance program for health disparities is really not feasible at this time. And the third is to sponsor high quality training of staff at health plans, health centers, and public hospitals on the theoretical framework for understanding health disparities work. Considering partnering with the California Healthcare Foundation for these efforts. My written testimony includes some additional material. I do want to highlight, though, on the last page, additional data needs, because it was brought up by Dr. Lown. He talked about the more detailed data that really does need to be systematically collected at the primary care level. That's the only place that data is going to be accurate. The Institute of Medicine released a report last year called Capturing the Social and Behavioral Domains in Electronic Health Records that has very specific recommendations for data elements to be collected. But how can California impact that? Because it is, after all, this meaningful use is federal. Well, the California legislature, or DHCS may consider making some of this data collection a condition for doing the health center alternative payment methodology pilots. To lay the groundwork for capturing this data and really showing the impact on disparities in that payment methodology. And of course, the supporting health information exchange efforts, as Dr. Lown implied, is absolutely critical for this to be rolled up together. And lastly, another ask that relates to the state is linking vital statistics data with Medi-Cal enrollees to allow analysis of outcomes by health plans. Right now, we do not have access to birth and death data, and it's really hard to analyze significant outcomes without that. So I'll be happy to entertain any questions about what the health plan is working on.
Thank you very much. Senator Chavez, you had a question?
This has really been a very informative hearing the past couple hours for me. Very impressed with all the data we're trying to capture. Very impressed with yours. I like why we're doing this issue about, quality of life. One of the things I was looking at, I was just wondering, because I'd been involved in some projects before on trying to manage systems. And I guess this would go to you, Mr. Lee. I said, how much, from your perspective, managers, how much is it going to cost to put the system in with software, hardware, training, management? How much is that time invested? How much is that? If you had 100% window for care, is this one like only 1% of the cost, or is this 10%, or what? How much is it going to cost to do this?
I hazard to get into this. Some of my colleagues who actually run health plans and are at the provider level are more appropriate, but I think that having information to support the delivery of care is a small slice of what the entire cost of care is. And without having that, we can't deliver better care. So I don't know the specific slice, but it really is an issue of without having data to understand where to focus, what the problems are, we can't improve. So I don't know, is it 2%? I mean, you look at the overall healthcare dollars, an electronic health record that is well structured is a tiny portion of what is spent overall in the healthcare dollars. So,
yeah, I talked to my son, who's a doctor, and he telling me that the time that he used to spend doing with the patient, now that he's going through a 15-page paper, is non-value added. You could hire people to do that. I'm just wondering. So, maybe he has a different perspective than you. Any of you others want to take a stab at this? How much it's going to cost?
So Sarah Brooks with DHCS, I think, and I would agree with Peter Lee in that we don't have a dollar amount. Obviously it would cost money, but I think that we would argue that in the long run there would be savings from providing better quality care and from avoiding emergency room usage that's not necessary, inpatient stays that are not necessary, decreasing the number of people with diabetes and other chronic conditions.
You know, in 1974, the end of the Vietnam War, the military decided to go to the Chevy model, GM model, Ford model, and manage all our motor transport fleet. And so they made this huge computer thing, and they took a bunch of guys. I was one of the young second lieutenants that went away to school to Georgia and sat there for 6 weeks and learned how to work this database and figure out how many tires I was going to use, and how much gas and maintenance and miles and weights. And this way we had fleets on the East Coast, West Coast, Pacific, and we could float these around. And we had this whole life cycle management system from the time it came to the time it went away. And 15 years later, I was watching it, and there was a gunnery sergeant that had a board on his desk, and he'd just write down the truck was up or down. Because it was so much information, it wasn't all valued. I mean, it was just like huge. And so since that experience, I always watch systems, and I'm wondering, systems are best when they're some way able to suck the data without requiring a person. Because if you require a person to push a deal, the button, or say, yeah, this, that, and that, and that, and that, pretty soon they start pencil whipping it. That's a military term. And don't do anything. And so I'll be watching this with interest, see if it's, I guess I get to be another 8, 9 years. So I guess I ask a question, say, how did that anything work? Thank you.
Any other comments, questions? Assemblymember Wood.
Yeah, I have a couple questions. First one for Sarah from DHCS. You mentioned early on in your presentation, you talked about monitoring like appeals, and can you kind of walk through that again for me? Because I want to. There's something you said that I want to grab.
Sure. So it was just talking a little bit about some of our recent efforts related to data analysis. We did recently standardize our collection of grievances and appeals data from the health plan. So previously, we received the data quarterly, but it was in different formats. And so it wasn't really it took a lot of effort for us to consistently look across health plans in terms of what was happening, but we also didn't have the ability to drill down into kind of that beneficiary-specific level. So now the health plans actually submit beneficiary-specific information to us, which has much more detail about what the grievance and appeal was filed for, and then we're able to take that data and stratify it and look at what's happening in a certain race or ethnicity, by age, in a geographic area. So we can really look at, are there specific areas within a health plan or across health plans that need to be addressed, and we can work with the health plans then to ameliorate those issues.
So you're gathering that information from the plans themselves?
Correct.
Okay. Is there any process by which providers can have input on that to cross-tabulate? And the reason I ask is I've heard anecdotally that there are denials of authorizations from some plans for certain procedures and things, and providers are a little frustrated by that. So I'm curious: is there a process by which providers can be engaged in the process so that basically to know that the data is correct?
I think that's an excellent question. Definitely providers can file with the plan as well, and so that information comes to us also. So even though I talked about the beneficiaries, we get provider information as well from the health plans. But I think you're asking about perhaps did maybe a beneficiary not file a grievance for something, or did that not make it into the data that we received? We haven't explored that, but definitely are working closely with our providers in terms of gathering information to better understand how they're working with our health plans. And the other thing I would just mention is that we are looking now at authorizations, because you mentioned authorizations specifically, just looking at timeliness of approvals and denials, or if they're being deferred for additional information timely, but also looking at whether or not the plans are using the appropriate utilization criteria to determine if they should approve or deny them.
Okay, I guess part of what I've heard is that there are certain procedures that seem to be, at least in some areas, routinely denied.
Okay.
So I'm for services that should be covered.
And I can address just from the front lines of the health plan. Whenever there's a member grievance, we always call the provider to, if the grievance team is the advocate for the member, And so their job is to try to resolve that issue. And so they contact the provider they look at what the reason for the denial was. And often it's because a provider didn't submit information. Sometimes it's for medical necessity, but sometimes it's because they didn't justify it, and it was justified. And so there's a close communication with that provider as part of the grievance process.
And are there other appeal processes beyond that then? Department of Insurance or managed health care?
Yeah, certainly, providers can go to the Department of Managed Healthcare. There's a state fair hearings and an independent medical review process for beneficiaries through Department of Social Services and DMHC, but also they can email me. Maybe I shouldn't say that right now, but I frequently receive emails and I'm happy to look into
As
things.
long as it's not on your personal email.
Right, no. I'm staying away from that. But definitely, if you do have providers that have concerns, I would encourage you to ask them to email me, and I'm happy to follow up and talk with them about their concerns.
Well, I guess the bottom line, I just would like to be sure that it all kind of balances up at the end of the day, that if there are appeals, that they're accounted for and the numbers all add up.
Yeah, I mean, the other thing I would just note is that DHCS now is auditing our health plans annually through our audits and investigations area at the Department of Healthcare Services, and we work in coordination with the Department of Managed Healthcare, who goes out triannually to do medical surveys. And that is a component that A&I does look at through their medical audit. In follow-up to the report that we might get from A&I that might say, for example, to your point, that a plan is disapproving certain authorizations that they shouldn't be, then we work with the plan on a corrective action plan, and they have to actually demonstrate to us that they've come into compliance, and it's not just, this is what we're going to do. They have to actually show us that they've done it. And so definitely are working to continue to strengthen our efforts around monitoring the health plans and working with them to provide technical assistance when they need to better have better support in terms of implementing the program. Thank you.
And I had
Sure.
I had a second question. That was actually for Mr. Lee, and that just goes to, I'm just curious, obviously we know that people are re-enrolling now for Cover California. Is there any data collected from anybody regarding, are the plans meeting expectations? So are people, especially with people who have never encountered insurance before, are they actually getting what they think they're getting? Do they understand the product appropriately? And is there a utilization appropriate as you might expect for the general population, or are we getting overutilization? Or in some cases, I know certain populations will underutilize and wait till the very last minute to actually get care. I'm sorry, I threw like 5 questions.
There was at least a few in there. But
Yeah,
first
I've got them written down too. So
yeah, first, we're working right now with a national partnership to have what will be a standardized survey, not just in California, but across the nation, to see what are consumers' experiences in health plans through exchanges. And so, did they understand it? Did they think they got, access to care on a timely basis? This is something that is standardized right now in terms of health plan surveying, but to understand for those that are in exchange plans, what was their experience? Did they knew what they got? Did they get access to care when they thought they wanted to, et cetera? And so that's a survey process they're actually in the process of piloting right now, and it's going to be annual starting next year on a regular basis. We'll be able to see that. But we're piloting that right now. In terms of utilization, this really goes to the point of having our clinical analytics capacity. So we can actually say, how many visits should you be getting? And what's the right number? Is it too much or too little, et cetera? And it's really about right care at the right time, and see, it's not a particular, some care can be too much, some can be too little, but the issue is, are we seeing differences? And this is the question about collecting data is not cheap, but it's a lot cheaper than not getting people the right care at the right time. And understanding what is happening by ethnicity, by education, by language is the key thing I think you're hearing across all these panels that we need to get to.
Great, thank you.
I believe Assemblymember Chu, you had a question?
Thank you, Mr. Chair. I had a couple of questions around the collection of LGBT data. My first question is to DHCS. So a couple of years ago, Governor Brown had convened the Let's Get Healthy California Task Force, and it was co-chaired by HHS Secretary Dooley. And throughout this report, it references the following: given the diversity of California, the task force believes differences by sexual orientation and gender identity should be tracked where data are available. Such data are crucial to eliminating health disparities and informing which strategies and interventions are prioritized. I'm wondering, I know there's been some progress in Covered California, and I'd like to ask Mr. Lee a question about that, but outside of Covered California, could you talk to us about whether there have been efforts to collect more data?
Sure. So what I can tell you is that the department is in discussions around adding LGBT questions and similar questions to surveys, for example, that we are conducting. So we're going to be doing, in partnership with the California Healthcare Foundation, a survey of all of our Medi-Cal, well, not all, a sample of our Medi-Cal beneficiaries. That would be a lot, yeah. But we will be asking questions about LGBT and similar questions in that survey, because we do think it's important to start collecting that information. Also are in discussions with the federal government about potentially adding that to our Medi-Cal application as well.
Okay, thank you.
Thank
and
you.
then to Mr. Lee, first of all, I want to thank you. I know that the LGBT caucus had requested that Covered California begin to collect this data, and you had referenced in one of your slides some of the work you're doing in that area. Mm-hmm. I was trying to decipher the language in that slide, and if I could just read, it's on page 20. It says, Covered California is working with the qualified health plans to collect the data. So the qualified health plans are now asked specific to how and if the carriers collect gender identity and sexual orientation data and how that data is used. So are you collecting the data, or are you asking the health plans if they are collecting the data?
There's two tracks. One, we're asking the plans how they're collecting to understand what they're doing. The issue with regard to how we collect the data really is an arm-in-arm issue with DHCS, because it's a single streamlined application for both. And so we're in discussions and with CMS on what that would look like. So we would actually collect it, whether it's coming in the door for Medi-Cal or Covered California. So that's an arm-in-arm initiative, so to speak, relative to what we would be collecting at point of entry. And again, we've had discussions with CMS about that, and this is groundbreaking for them looking at what they're doing nationally. But I think California's in the right place leading these discussions to see how to have it in a way that would collect data as robustly as we could.
Great. And I want to just say I very much appreciate your efforts, and probably my staff will contact you to see if we can understand exactly where the state of play is with this information.
Happy to.
So my question is to DHCS with regard to the data, collection of data. Who will be analyzing this? And once you determine where health disparities are, what are you going to do to reduce those? Is that going to be put upon the providers, or how do you go beyond that to reduce the healthcare disparities?